Okay, so my last talk is about status. We're going to start with a question about whether it's easily terminated, is defined as seizures lasting longer than 2 to 3 minutes, if non-convulsive is not associated with brain damage, and a comatose patient can sometimes be detected only by an EEG. E is most commonly caused by trauma. Okay, good. So most people got the fact that we need to get an EEG on these patients, and we'll talk about that, about how it is not easily terminated. It's lasting usually seizures longer than 5 minutes, and if it's non-convulsive, it is typically associated with brain injury, and that it is not mostly caused by trauma. The patients that with status epilepticus, the definition previously used to be that it persisted for a sufficient length of time and repeated frequently enough to produce a fixing and enduring epileptic condition. That sounds like a neurologist definition, right? Very fuzzy. So the duration then went back to when was damage occurring. And the first animal models actually was 60 minutes, and then that moved down to 30 minutes. So they typically saw there was neuronal injury that was seen in animal models at the 30-minute time. We know that by quick termination, it will decrease the chance that the seizures will continue. But remember that most seizures last about 3 to 4 minutes, and then usually the brain depletes itself and it quiets down. So the feeling was that we know that neuronal damage is happening at 30 minutes, but operationally, we're going to say 5 minutes of either continuous seizures or 2 or more discrete seizures without the patient recovering consciousness during that time. We know it happens in about 10 to 40 per 100,000, so behind stroke, it's the most frequent neurologic emergency that we see that causes major morbidity and mortality. So the reason why I'm looking at this is that if you have the probability of the seizure terminating, it's going to happen either fairly quickly or after this period of time, about 7 to 9 minutes, the chances that that's spontaneously going to stop goes down to almost 0. So that means that if it's lasting longer than this period of time, we have to do something to stop it. We know that mortality goes up if a patient is seizing for less than 60 minutes. It's still some mortality here, but as they're seizing longer and in that status, mortality goes up because of the damage that's occurring. So, and then we saw this slide already. So the etiology of status epilepticus most commonly are patients that have epilepsy but are not taking their medications. Next is going to be alcohol, and then you can see trauma was not the correct answer because it's down in this 6%, but it is a cause, and you can see stroke is 5%, anoxia. So most likely going to be patients with epilepsy who aren't taking their medications. Now, I mentioned I would talk about with trauma that we use phenytoin. So the study came from Temkin that showed that if they looked at patients that had trauma and treated them with phenytoin. In those days, they only had phenytoin. Phosphenytoin, by the way, is a phosphorylated ester of phenytoin. So what happens is that brings the pH of the phenytoin solution down from something like 10, which is very alkaline and can be very toxic if it extravasates, down to closer to 8. So that the phosphenytoin is very quickly cleaved by esterases in the blood from phosphenytoin to phenytoin, so it drops blood pressure less. So if you have a choice, you want to use phosphenytoin. But the study was done with phenytoin and showed that at day 7 that the frequency of post-traumatic seizures was down to 3.6 versus 14. So that's why guidelines recommend that we treat patients with closed head injury or traumatic brain injury also open for 7 days. And then we stop after that because the study actually showed at 1 year it didn't make a difference and at 2 years. So we really don't know if we should be treating at 14 days versus 7 days, but the guidelines read 7 because that's where our evidence-based literature is. And it's just showing placebo versus phenytoin, so much more effective. Now, levetiracetam then came out, and parental anti-epileptics previously were very few that we would use So now that levetiracetam came out, that is a drug we don't have to follow levels on, doesn't drop blood pressure. So there have been a lot of a meta-analysis looking in small studies, and then a meta-analysis that looked at this and showed that it was non-inferior to phenytoin. But then more recently, just so you're aware, NABA did this nice study that came out in 2013, actually twice as large as the Temkin original trial that used phenytoin alone, looked at their 7-day seizure rate and saw it was non-inferior. So we know that we can use now levetiracetam versus or phenytoin. Now, there's been a recent study that just came out since I turned in this syllabus that showed that if you had actually a mass lesion like a subdural, that probably it was better to use phosphenitoin rather than levetiracetam. But just be aware, because it won't be on the boards, but if it comes up whether you should be treating these patients with anticonvulsants, it's 7 days that you should be treating them with this. So status epilepticus is bad because there's a lot of excitatory amino acids that are activated by this, NMD and AMPA glutamate receptors. There's decrease in the neuroprotective neuropeptides, and then there's a reduction in the GABA-mediated inhibition of the hippocampus. And that's one of the issues that's happening. Remember, our benzols work on the GABA receptors. So the seizures alter the GABA receptor function, and it's decreased potency. And this is a problem for these patients. We'll come back to that when we're talking about using medications. How do we classify status epilepticus? There's no commonly accepted classification, but it's useful to know generalized convulsive is our typic tonic-clonic convulsive status epilepticus. Simple partial means that a patient is having some movement of one limb and then some changes in mental status. Those patients can be actually awake and talking, though, before they have some change in mental status. That is not a medical emergency. Myoclonic status is important in patients who have had a noxic injury. So if you see a patient who's had a noxic injury and you start seeing them with facial twitching and it's very arrhythmic, that's what we call myoclonic, and that's been classically a very poor prognostic factor. Now with the hypothermia, the therapeutic hypothermia after cardiac arrest, it's less severely prognostic than it was before, but before when you would see myoclonic jerking, so again, it's arrhythmic, it's not the classic tonic-clonic, so you see a jerk here, legs jerk, face jerk like this, and it continues on. But that is a poor prognostic factor, so it's important to be aware of that entity. And then the non-convulsive status that we have to pick up by looking at EEG is in that as well. So when we're looking at the EEGs through the phases of status epilepticus, initially it's the brain with discrete seizures, then merging seizures, continuous ictoactivity, and then there's flat periods as the brain starts becoming depleted, and then there's periodic epileptiform discharges. So it looks like this. So the brain should never look synchronized. It shouldn't look like your heart. And this is a normal EEG. And then what happens here is you see this synchronization that's not good in a seizure that generalizes here. So you can see it starts focally and generalizes to the rest of the brain. I was told by a nurse, I know when they're seizing because it looks like VTAC of the brain, and that's exactly what it's looking like. You don't want to see anything synchronizing here. So this is a discrete seizure. It's starting to merge. Then you have this continuous but periodic ictal activity. Then it starts depleting a little bit, and that's the last phase. Now, the important thing, and you look at this is from Eric Lothman showing that the motor, you'll see generalized seizures, then you might see some myoclonus, and then you have what we call electrocerebral dissociation, where the brain is still seizing, but we don't see anything anymore in the motor manifestations. So this is the EEG that we talked about. And then systemically, with all the adrenergic and epinephrine surges, the blood pressure goes up, the heart rate goes up, you have more lactate, glucose may go up with the epinephrine surge, the pH goes down as the lactate builds up. And then as things go on, the blood pressure normalizes, and then things more normalize here. Brain damage occurs here with the continuous, it goes faster. With non-convulsive, there's still brain damage as well, but it just takes a little longer to ensue. So, and then the oxygenation, it depletes. So this is what's happening when the seizures continue. So monitoring is essential because you may not see this. The patient may just have a little bit of twitching of the eyelid, maybe subtle facial, or maybe just a patient who's not waking up. So it's important if you suspect something or you're curious why this patient is still not waking up, you got to get an EEG on board. So Clausen put together a lot of nice the studies that had been looking at these patients with acute brain injury that are unexplained, persistent, altered consciousness, and looked at EEG. So if you look at TBI patients, you can see in this that it can be anywhere from, well, 0 to up to 33% of patients may be having non-convulsive seizures. In the subarachnoid patient, anywhere from 3 to 31%, and then in ICH patients, anywhere from 18 to 28% might be seizing. So you have to suspect this in patients who aren't waking up. If there's patients with CNS infection, one group was 33% were having non-convulsive seizures, much rarer in ischemic stroke. Until much later, maybe usually months and months later, but in mixed neurologic populations also has been seen. So if you work mostly in the medical ICU and you're saying, well, I don't see a whole lot of seizures, I don't need to worry about this. In this one study, there were 22% with seizures or periodic epileptiform discharges. 67%, two-thirds of these were purely electrographic. You had no idea that these patients were seizing. 32% of those patients had sepsis versus patients that were without sepsis was 9%. And if they were seizing with the periodic epileptiform discharges, death and disability was 89% versus 39%. So it really is important to look, even if you're in the medical ICU population, to make sure they're not in non-convulsive status. So here's a 45-year-old man admitted with hemoptysis, has metastatic lung cancer. He has tonic-clonic seizures, and you're called to treat him. The episode lasted 5 minutes and persists. The medication best used at this time is IV diazepam, lorazepam, fosphenytoin, valproic acid, or levetiracetam. Okay, good. So most of you picked lorazepam. So we're going to show you why you don't want to use diazepam in this next slide. So the first few minutes are critical, as I mentioned, that you want to prevent the seizure from continuing. And I talked about the fact that the GABAergic receptors are modified, and this shows in rat study that the animals that are seizure-free, that if they've been seizing 10 minutes versus 45 minutes, there's a logarithmic increase in the amount of diazepam it took in this study to stop the seizures. So the longer you wait, the harder it is to treat. So which drug do you choose? So it's a little hard to see the dots here, but the solid dot is lorazepam, and then this open dot is diazepam. So diazepam, remember, very lipophilic, goes across the blood-brain barrier, works very fast. But what happens is because it's so lipophilic, it comes out of the brain and plasma goes into fat stores very quickly, so it's not there to stop the next seizure. We use it in the epilepsy monitoring unit all the time because we want to see many seizures start because we want to know where it's starting from. So diazepam is going to allow the next seizure to come on fairly quickly. Lorazepam is going to come into effect just a little slower because it's not as lipophilic, but it's going to last longer until you get another anticonvulsant on board. But the first drug you choose is going to be a benzodiazepine, which is why the phenytoin was not the first drug of choice when you're dealing with an acute seizure. It's going to be a benzo. This is showing in the pre-hospital treatment of status epilepticus study by Aldridge that if you looked at placebo and the proportion seizing, doing nothing, they're going to still be seizing, which makes sense. Diazepam worked, but the lorazepam actually worked for a longer effect. So you want to use lorazepam. Now, having said that, there's a new study, the Rampart study that came out, and then was looking at what should our paramedics use, because most cities don't have lorazepam in the field because it needs to be refrigerated. It needs to be colder. So San Francisco uses it, but most places have diazepam. So they thought, well, let's look at the choice of using intramuscular versus intravenous therapy. So intramuscular midazolam versus intravenous lorazepam. And starting at the bottom here, just knowing that, so it's IV lorazepam. If you give it, once it's in the patient, it works faster than midazolam. But the issue is this: the time from opening the box to acute treatment was longer because you had to get the IV started. The IM is very quick. and then the time from the box opening to stopping the cessation, because it took a little longer to get that IV in, it's a little longer with the lorazepam than the midazolam. I'm not going to go through this complicated study, rest of the study, just to be aware that the complications were not statistically significant as far as intubating the patient, hospitalizing, ICU admission, recurrent seizures, or hypotension. But the bottom line is this, is that we need to stop the seizure rapidly. If you have IV access, use lorazepam. If you don't have IV access, use IM midazolam. That's what this study shows, so that's the choices. If you don't have either of those, then obviously you want to use diazepam, but just know it's going to work it'll work for only a short period. You need to get something else on board. I'm going to refer you, if you're interested, to these particular guidelines that came out from the Neurocritical Care Society in 2012, which covers all of that except that most recent Rampart study. So our management that we're going to take on for these patients is, in those first 5 minutes of seeing the patient seize, is you make sure their airway's okay. You're going to turn them on their left lateral decubitus, or their lateral decubitus position for rescue therapy. You may not need to intubate them. All the ER doctors love to intubate our seizure patients and paralyze them, but a lot of these patients have epilepsy, and if it's a seizure that started in the ER, you can usually give them medication, turn them in the rescue position. You're trying to get an examination, find out what's going on, get the IV lines in, and you're getting the laboratories as well to try and figure out why the patient's having seizures. Just be aware that these particular medications like theophylline, isoniazid, tricyclics are a cause for status in these patients. Remember that these patients are going to have lactic acidosis because of what's going on with their muscles, so getting an ABG is really not going to help you very much. They're going to be acidemic. You can pretty much guess that they're going to be so, but you do want to make sure they're satting well and they're oxygenating. And then you want to get them to imaging if you're concerning, again, even if they're an alcoholic, they may have a subdural going on as well. So the D50 is something that you might consider with some thiamine, but you consider that it might be hypoglycemic. And while you're doing all this, you're trying to stop the seizure. And again, there's the lorazepam, but I would say that if you don't have access, get that the IM midazolam on board. So don't over-treat the blood pressure. Remember, you have that, as we showed before, all that adrenergic surge. The blood pressure is going to be high as soon as you give these medications to stop the seizure. One, those are going to drop the blood pressure, and also stopping the seizure will drop the blood pressure as well. So don't over-treat blood pressure with antihypertensives. Use the benzos as the first line, but it's going to briefly terminate those seizures. You've got to get something else on board. So you want to treat definitively with another anticonvulsant. You have to worry about recurrence in successful termination of status, because they've shown in the VA cooperative study that 11% can go on to have overt seizures and then subtle seizures in 20%. So if they're not waking up again, you need to get an EEG on board. So here's an algorithm that you could use: is the lorazepam initially, fosphenytoin, get that on board, and 18 milligrams per kilo. On each of these slides, and I'm not going to go over this, I just put in the mechanism of how this works in case you're interested. They're not going to hopefully ask you that on board questions, but it's going to be there if you're interested. For refractory treatment, then the lorazepam, if already given, you might consider it, but the infusion is a problem because of the propylene glycol. So usually we don't use lorazepam, but we'll go to midazolam or pentobarbital. The loading is typically, like we had talked about, it's about 5 to 10 or 5 to 15, so you can use 10 to 20 milligrams per kilo like we use with the ICP, and then propofol can be utilized as well. So just talking about the different infusions, midazolam is one of the tried and true, but initially slow IV boluses, then starting infusion. It can accumulate and it has a better side effect profile than lorazepam because you don't need the propylene glycol is not in the midazolam, so you don't need larger doses. For pentobarb, we covered that pretty much extensively with our previous talk, so be aware that that is on the GABA receptors as well, so it can be very effective. And then propofol is one you've heard earlier about this, and then the loading dose, and then followed by 1 to 15 milligrams per kilo per hour. Be aware, and you heard about the PRIS syndrome that is associated, but you'll sometimes see this epistatonus, neurologically, the epistatonus, the muscle rigidity, chorioathetoid movements as well, and myoclonus. Be aware that when you're titrating off propofol, that we often see reemergent seizures, so it's not usually my go-to. If they're ending up in the neuro ICU with status, I don't usually use propofol. I usually go to penobarb because it quiets the brain and reemergent seizures are seen less frequently. So this is showing that getting an EEG in patients that don't return to baseline is important. I already mentioned that a little bit, but this is showing that patients, that in some group of patients, 17% were conscious within 12 hours, and that had none of status, but this particular group of patients, 48, after they had previously stopped seizing, were back in non-convulsive status versus a 14%. Also seen in another small subset of status epilepticus. And then patients with altered mental status, again, this is showing that these patients with their altered mental status was 37%. So if you thought you stopped the seizures and they don't wake up, again, you need to get an EEG on board. If they go back into status after you thought that you stopped it, we get into the worsened prognosis of having refractory status epilepticus, where we've given everything and we think that we've stopped the patient continues to have seizures. Seen in about 24 to 43% of patients, the prognosis is worse. We have a laundry list of medications, which I'm not going to go through all of them, but just so you have that there. But I do want to mention a few words about a few. That the NMDA receptor antagonist, ketamine, can be very, very helpful to terminate status. In prolonged status, it's more effective. They've shown in an animal study that if you took animals that were seizing for a longer period and treated them with the barb, then they were more likely to stop with the ketamine than the barb. If they were seizing for a short time, they were more likely to stop with the barb than the ketamine. So if they're seizing for a long period, ketamine can be very effective. We're using the induction doses of 1 to 5 milligrams per kilo, and then I've never needed to go to the infusion, and usually if we've tried to use the infusion, it's not very effective, but some have used it. It's a dissociative anesthetic, so you're going to be using it with benzodiazepine or something else that you don't have that dissociation. Most of these people are comatose, but we still want to have something else on board. Prolonged infusion has been associated with cerebellar or cerebral atrophy, so another reason maybe not to use an infusion. Phenobarbital is out there, also works on the GABA receptors. And the typical is a 20 milligram per kilo loading dose. Watch for the barb effect of sedation, respiratory depression, hypotension that we saw with the other barbs. Now, valproic acid is another parental medication that we can use, also works on the GABA receptors. The pharmacists hate us when we use this because this has a lot of complications, a lot of interactions, can have some liver toxicity, but it is available to us if we need it. But it is, just be aware, it complicates a lot of your pharmacokinetics and other medications. Levetiracetam we talked about with traumatic, post-traumatic seizures, but can be used as works on the synaptic vesicles and the proteins there. Used in focal status epilepticus, it's not metabolized through cytochrome P450, and the metabolites are renally excreted, so we have to adjust for this. So just be aware, lacosamide has been tried as well, though there have been a few case reports showing it was effective. There was a rate case series that showed there's no evidence, but still sometimes when you're throwing the kitchen sink at patients, this is sometimes used, but not as effectively as some of the other medications. Topiramate's another medication that's out there. I'm not going to go into it in detail. Just be aware that your neurologists may say, well, I'm going to try and use hypothermia for status epilepticus, and there are articles out there for that. What we find is that, and you can see that the patient is having some seizures, you can stop it by cooling them, and this is a complicated slide, but just showing that once you can cool, this is showing seizures in the black bars, and so when they're hot, they seize. When you cool them down with this, they stop seizing, and then you warm them up again, they seize again. That's been our experience, is that as soon as you warm them up again, they start seizing again. So we don't use that very frequently unless we're getting something else on board. A study that's that's ongoing right now and is becoming more popular. This is a study that Hopkins has started. Is a ketogenic diet, which is very difficult to do in an ICU, but we do it with a tube feed called Ketocal, and you have to take everything that has any kind of sorbitol, like Tylenol, Elixir, or anything that has any liquid in it that you give down tubes cannot be given to the patient. So it's very difficult, but this has been able to terminate status in a few of our patients. So just be aware that that's out there. Some people have used electroconvulsive therapy for refractory status, so you're really reaching the bottom of the barrel. Be aware if you have a patient in status epilepticus or a patient who presents in the classic, and a potential board question may be a young woman who presents in the psychiatric ward for the very first time having psychosis and then is suddenly seizing and gets brought to your ICU. And then you work her up and you find out she's in status, and then scanning shows an ovarian cancer. So ovarian teratoma has been associated with NMDA antibodies that cause limbic encephalitis. Treatment is taking out the teratoma. Sometimes in these patients that have these paraneoplastic encephalitides, and this is a laundry list of them that's out there, and don't expect you to read it, but just be aware that they're there, is that you may treat them with steroids, IVIG, sometimes plasma exchange, sometimes cytotoxic agents. But if they have a cancer, testicular cancer has been associated as well, but the ovarian one is the most common one that you'll see potentially on a board question, is you want to take out the teratoma. So the outcome with status epilepticus is a mortality of 3 to 35%. You can have severe neurologic sequelae after that, but some will return to functional baseline. It depends on their age, so the younger they are, the shorter their seizures, and then the etiology. So if they have known epilepsy or anticonvulsant withdrawal or alcohol, obviously they're going to have better outcome than those that have a metabolic abnormality or someone with an infection or a anatomical abnormality like a stroke or head trauma. In refractory status, that mortality goes all the way up to 32 to 77%, but some will return to functional baseline, 35 to 39%. More are likely to have epilepsy afterwards, but you can sometimes treat these patients, so don't give up on it. So the practical way to treat your patients with status epilepticus or the ones with refractory, you have to have an EEG on these patients. They're going to be in the ICU for a long time, and your medications are going to probably drop their blood pressure, be prepared for infection. And then, unless they have a known CNS devastating injury, don't stop. We've had patients that do return to baseline, 35%. We've all had experience, those of us who work in the neuro ICU, of young people like this 19-year-old man who was in status for 3 months. We thought we could never stop it. He ended up waking up, walking and talking, going back to school, had a little bit of cognitive impairment. So don't give up on these patients even 3 months into it, so they can recover. So use a benzodiazepine for rapid termination. So if what I tell the nurses is if they run to the Omnicell and they're getting the lorazepam, if they've come back and the seizure's already stopped, that's probably the 5 minutes. So they don't necessarily need to give it, but I need to make sure that they have an anticonvulsant aboard. If they get back with the Omnicell and they're still seizing, give the medication, because that's at least that 5-minute period of time. So get that additional anticonvulsant on board, so you may be, and this happens in the ED all the time, they're like very happy they stopped the seizure with the benzo, but then I asked them, well, what did you load? And they said, well, no, I'm waiting for you to admit them to the ICU. Well, I know they might be seizing by the time they come back to me. So I have them load in the ED before they come up to us. Be aware of all the side effects, and you just need to support these patients. So that's it. Thank you.